Ever felt like you're trying to make sense of really complex medical stuff? Maybe uh, you're supporting someone going through it, or you're just naturally curious, but all the terms, it can feel pretty overwhelming.
Yeah, definitely. And that's kind of why we're here with the deep dive.
Exactly. We dig into this dense material, pull out the important bits, and, try to guide you through it.
Think of it as getting the key insights without having to wade through, well, mountains of technical information yourself. We really aim for clarity, a clear structure, so you can grasp the essentials.
And today, we're tackling a topic that, yeah, it deals with some very sensitive situations, but it's incredibly vital to understand stupor and coma.
Right. And for this, we're leaning heavily on a really respected source, the Bradley Neurology Review. We'll be looking at, what these states actually are, conditions that can mimic them, the initial approach doctors take.
And also the really tough aspects like prolonged unresponsiveness and brain death.
And because we are discussing some delicate subjects, especially brain death, we want to be clear that this is all based on the factual info in the Bradley text. Our goal is just a clear, organized understanding.
Absolutely. Breaking it down, avoiding too much jargon, giving you a clearer picture.
Yeah.
Okay.
So let's start right at the beginning. According to the Bradley Neurology Review, what is consciousness, fundamentally?
Well, the review defines it pretty straightforwardly. It's your awareness of yourself and, your surroundings. And this awareness can be altered in basically two main ways.
Okay.
First, you can affect the level of arousal, how awake or responsive someone is. That's mostly what we're focusing on today. The second way affects the cognitive and emotional functions, the content of thought, you could say.
So something like, say, Alzheimer's disease. That would mostly affect the content, right? Not necessarily how awake the person is, at least initially. Exactly, precisely. The source points out that those content disorders usually don't mess with arousal levels, except maybe in really advanced stages. But there are times it gets blurry. Delirium is a great example of that overlap.
Right, delirium. The Bradley Review mentions it can be tricky sometimes to tell if someone's less responsive because their arousal is down or if it's more about their thinking. It talks about the DSM-V criteria.
Yeah, it does. The DSM-V defines delirium as a disturbance in attention and awareness, plus some kind of cognitive issue, maybe memory problems, disorientation that develops pretty quickly, like hours or days. And it's not better explained by some other underlying neurocognitive disorder.
Okay.
But the interesting thing is how delirium presents. Someone might be hyperactive, agitated, affecting the content side, or they could be hypoactive, withdrawn, less responsive, which makes it look a lot like a decrease in arousal and just being awake.
So it's not always a neat box. It sounds more like a spectrum. The review uses that idea, a continuum from alert to coma.
Exactly. Think of it less as separate steps and more like a sliding scale of responsiveness. We use terms like alert, lethargic, stuporous, and comatose. Alert is, well, normal. Lethargy is a bit drowsy, but you can wake them.
Okay.
Stuporous means they're basically unresponsive unless you really, strongly stimulate them. And even then, it's brief. And coma. Coma is just complete unresponsiveness. No waking them up with any stimulus.
It feels like those middle ones, lethargic and stuporous, might be a bit subjective, open to interpretation.
You hit it right there. The review points that out. Because they cover a range, different people might label the same state slightly differently. That's why clinically, alert and comatose, the ends of the spectrum, are often the most precise, the most useful terms when you don't have more detailed descriptions.
Okay, that makes sense. So we have this range of wakefulness. But the review also makes a big point about conditions that look like coma but aren't. Why is it so critical to tell them apart?
Oh, it's absolutely vital for two main reasons, really. First, the therapy. Someone who can't move needs totally different help than someone whose brain isn't actually responding.
Right.
And second, prognosis. Understanding the true state helps predict the likely outcome.
The first one mentioned is locked-in syndrome. The name itself sounds pretty terrifying.
It is. It's a profound condition. The person is fully alert, fully aware of everything, but they're paralyzed, quadriplegic, often can't speak, is usually caused by damage right in the brainstem, the ventral pons area, often a clot in the basilar artery.
Wow.
They might retain some eye movement, usually vertical or blinking. But the key is that stark disconnect. Conscious mind, unresponsive body.
And the review notes similar states can happen with severe nerve problems or even certain drug poisonings. So the difference with locked in is the brain itself is still fully online.
Exactly. The awareness is intact. Now contrast that with the persistent vegetative state, or PVS. Here, people have lost all awareness of self and environment. No interaction. No sustained, purposeful responses. No language comprehension or expression.
But they do still have basic bodily functions, right? Like breathing, sleep-wake cycles. The review mentions they might even open their eyes or move spontaneously.
That's correct. Those automatic functions keep going. You might see eye-opening reflex movements, but no following commands, no speaking. What's fascinating, though, and complicates things,
Yeah.
is that some advanced imaging, fMRI, EEG, has shown hints of hidden brain activity in a few patients who meet all the PVS criteria clinically. It suggests maybe, just maybe, some information processing is happening even if they can't show it. Raises big questions.
That really underlines why you need to be so careful with the diagnosis and avoid those vague terms the review warns about, like Apallic syndrome.
Absolutely. And then, to add another layer, there's the minimally conscious state, MCS. The Bradley review actually suggests MCS might be much more common than PVS.
And the key difference is there is some awareness, even if it's minimal and maybe inconsistent.
Exactly. The diagnostic criteria look for things like following simple commands, even if inconsistently. Giving a yes-no answer, maybe verbally or with a gesture, saying intelligible words, or showing purposeful behavior linked to the environment, like reaching for an object appropriately.
Okay.
But sadly, the review points out a significant misdiagnosis rate. People in MCS getting labeled as PVS, often because subtle signs, like the ability to track something visually with their eyes, aren't fully appreciated.
That eye tracking seems like it could be a really crucial clue then, a sign of some connection.
It really is. And again, like PVS, imaging in MCS patients sometimes shows brain activity responses. The review also defines emergence from MCS. That's when someone can reliably communicate functionally or use objects correctly.
The review then mentions abulia, catatonia, and pseudocoma, also things that can be mistaken for true coma.
Yep. Abulia is severe apathy, lack of motivation. They're alert, aware, but just don't initiate speech or movement. Catatonia is usually psychiatric lack of movement, mutism, and pseudocoma is appearing comatose without any underlying medical cause, structural, metabolic, or toxic.
It just hammers home how vital a really thorough neurological exam is to sort these out. Okay, let's switch gears. What happens when someone is in a true coma? The review stresses the initial approach is an emergency.
That's the absolute first principle. Until they're stable and you know the cause, it's life-threatening. The immediate goal is minimizing potential permanent brain damage from anything reversible. You need a routine, fast diagnosis and treatment. Time is brain, basically.
And the review gives those three main buckets for causes, right? Structural, metabolic, toxic, and psychiatric.
Yes, those are the big categories. Structural lesions, meaning physical damage in the upper or lower brain. Metabolic or toxic issues like overdoses, severe diabetes complications, organ failure, and psychiatric causes. Often, the history and the initial physical exam point you towards one category or another.
And the review really emphasizes doing repeated exams and documenting everything precisely. Why is that constant reevaluation so key?
Because the patient's state can change, sometimes really quickly. Subtle declines in responsiveness can be the first warning sign of major trouble brewing deeper in the brainstem, affecting breathing, blood pressure, critical stuff. Careful documentation lets you track trends improving, stable, or worryingly declining. It guides everything.
Okay, so that first rapid assessment, what are the immediate, go-to steps and emergency treatments Bradley recommends?
Priority 1, medical stability. ABCs, airway, breathing, circulation. Make sure they're okay before digging deep into the cause. Rule out anything needing immediate surgery or intervention. Then empirical treatments treating likely causes before you have all the test results back.
Like what specifically?
Supplemental oxygen is standard. Then IV thiamine, at least 100 milligrams, and IV 50% dextrose, usually 25 grams, but crucially, after drawing blood for a baseline glucose level.
Okay, oxygen, thiamine, glucose. That makes sense for covering basics like low oxygen or low blood sugar. But wasn't there some concern about giving glucose if the coma might be from, say, lack of oxygen or a stroke?
That's a really important nuance. There is a theoretical risk that glucose could worsen damage in those specific settings by increasing acid production. But the Bradley review makes a couple of key points.
Okay.
First, severe hypoglycemia, low blood sugar, is a common cause, and it's treatable potentially with great recovery if caught fast. The damage from untreated hypoglycemia is severe and permanent. Second, the prognosis in severe anoxic or stroke-related coma is often grim anyway. So the potential benefit of treating hypoglycemia generally outweighs the theoretical risk. But, and this is vital, Always give thiamine with or before the glucose
Why is that?
to prevent Wernicke encephalopathy. Giving glucose to someone low on thiamine can precipitate this serious neurological condition. So thiamine first or together with glucose.
Got it. And naloxone was mentioned too.
Yeah, naloxone or Narcan. That's considered if you suspect an opioid overdose is the culprit. The dose is usually 0.4 to 2.0 milligrams CV. The main caution there is if the person is opioid dependent, reversing it suddenly can trigger a really nasty withdrawal syndrome.
So during that quick initial check, what are doctors looking for specifically? The key things.
It's a rapid but focused exam. General appearance, vital signs, blood pressure, pulse, temperature, respiratory rate, and effort, listening to the lungs, assessing their best response to stimulation, verbal first, then painful if needed, checking pupil size and reaction to light, looking for any abnormal posturing or involuntary movements, and if trauma is suspected at all, neck stabilization is paramount until the spine is cleared. Plus, securing the airway and getting IV access are immediate actions.
The review also mentioned diagnosing abdominal problems can be harder in coma.
Yeah, that's a good point. The usual signs of a serious belly issue, like abdominal rigidity, might be masked or absent, especially after blunt trauma. So if there's trauma history, they might need a CT scan of the abdomen or even a procedure called peritoneal lavage by a surgeon to check for internal bleeding.
And what about specific vital sign problems that need instant action?
Definitely need to intervene immediately for things like dangerously low blood pressure, shock, really high blood pressure, hypertensive crisis, a heart rate that's too slow or causing low blood pressure or very high fever, or any physical signs suggesting the brain is herniating, shifting under pressure.
Okay. And what about a lumbar puncture or spinal tap? When does that come into play?
It's considered mainly if there's fever or signs of neck stiffness suggesting meningitis.
Right.
But, and this is a huge but, you must do an eye exam first, looking for papilledema, which is swelling of the optic nerve head, indicating high pressure, and usually get a CT scan of the head before the LP. Because if there is high pressure or mass lesion, doing an LP can actually cause the brain to herniate downwards, which can be catastrophic.
No.
The risk is estimated at 112%, so it's taken very seriously. If bacterial meningitis is strongly suspected, you give antibiotics and steroids urgently, ideally within an hour, even if you have to delay the LP. But you try to get blood cultures first. And you should have medications like mannitol ready, just in case things go south after the LP. Also need to check clotting factors before the procedure.
Okay, that makes sense. The review then outlines common ways coma presents. I guess these scenarios give clues.
They absolutely can. Sometimes it's expected, like a known brainstem stroke getting worse, or someone with COPD getting too much oxygen and retaining CO2. Sometimes it's an unexpected complication like lack of oxygen after a cardiac arrest, or maybe a totally unrelated stroke in someone with, say, thyroid disease.
Or it could be someone with no known history presenting in a coma.
Exactly. Sometimes the cause is obvious, like major trauma. But often, they arrive with no clear reason. The big takeaway is, approach every coma patient systematically. Don't get tunnel vision based on what seems obvious.
And getting the history is crucial, but the patient can't talk. So who do you talk to?
Anyone and everyone who might know something. Relatives, friends, bystanders, paramedics, police. Phone calls can be vital. Checking their wallet or purse for medication lists, doctor's cards. You're piecing together their background, prior medical history, the circumstances of how they were found.
What kind of clues are you looking for?
Drug paraphernalia suggests overdose, and the review reminds us to think about newer synthetic drugs too. Finding insulin suggests potential hypoglycemia. Heart rhythm meds point to possible cardiac causes. Anticoagulants raise suspicion for brain hemorrhage. If it was an accident scene, was the loss of consciousness the cause or the result of the accident?
The review also has a specific section on coma after surgery. That must be particularly alarming.
Very. You consider all the usual causes, of course, but there are specific post-op concerns. Fat embolism, where fat blocks brain vessels, Addisonian crisis, adrenal failure, severe low thyroid, Wernicke's, especially if they got lots of IV fluids without thiamine, even accidental narcotic overdose from pain control.
And what specific historical details are most helpful?
You want to know about recent headache, fever, seizures, stiff neck, any weakness or numbness, vision changes, balance problems, incontinence, past psychiatric history, recent infections, travel history can be relevant. Nausea, vomiting are common in poisoning. Witness observations are gold. Did they see head trauma, seizure, weakness on one side, droopy eyelid, unequal pupils, slurred speech, how fast did it happen. Gradual decline often points to metabolic or infectious causes, while sudden onset suggests vascular events like stroke or bleed. Family can be key for psychiatric history, but you have to remain objective.
Okay, so after gathering history, the general physical exam comes next, providing more pieces. The review is really systematic, starting with vitals again, but digging deeper. Blood pressure, high or low, can be significant.
Definitely. Low blood pressure, hypotension, if severe enough, can cause coma simply from lack of brain perfusion. Causes range from dehydration, hemorrhage, heart attack, sepsis, drugs, Wernicke's, Addison's, lots of things.
And high blood pressure.
Hypertension can cause coma and a hypertensive crisis, or it can be a reaction to brain injury like stroke, hemorrhage, or increased intracranial pressure. There's that specific Kocher-Cushing reflex, high BP, slow heart rate, irregular breathing, strongly suggesting increased pressure, especially in the lower brain or in kids.
What about heart rate and breathing rate patterns?
Slow heart rate, bradycardia, besides the Cushing reflex, can be from heart blocks, certain drugs like beta blockers or poisons. Fast heart rate, tachycardia, might indicate low volume, fever, hyperthyroidism, anemia, various toxins. Breathing rate and pattern are super important. Fast breathing can be from low oxygen, high CO2, acidosis, fever, liver disease, drugs, sepsis, pulmonary embolism. But specific brainstem lesions can also cause characteristic abnormal breathing patterns, which we'll get into. And metabolic problems can affect breathing too, sometimes alongside a brain issue, complicating the picture.
Temperature, too. The review says use a rectal probe. High or low temps, what do they suggest?
High temp, fever, usually points to infection, often prompting that LP discussion. But lack of fever doesn't rule out infection, especially in the elderly or immunocompromised. Rarely high temp can be neurogenic from brain damage itself, like after subarachnoid hemorrhage. Heat stroke, drug toxicity, or other causes. Low temp, hypothermia, slows brain metabolism, causing decreased consciousness. Causes include cold exposure, metabolic issues, shock, sepsis, low thyroid, pituitary problems, Wernicke's, drugs, or specific hypothalamic lesions.
Beyond vitals, just the general appearance can offer clues. Clothing, body type.
Absolutely. Torn clothes might mean assault. Vomiting could be high intracranial pressure, drugs, metabolic issues. Incontinence might suggest seizure. A Cushingoid look-around face. Central obesity hints at adrenal issues. Being very thin, cachectic, points to chronic illness, cancer, maybe Addison's or thyroid problems. Liver disease signs like jaundice or spider veins in an alcoholic. All potential clues.
The review then goes through a really detailed head-to-toe exam. It seems incredibly thorough.
It has to be. Head and neck exam might show trauma signs, scalp cuts, raccoon eyes, or battle signs suggesting skull base fracture. Neck stiffness, meningismus, suggests meningitis or blood, but might be absent in deep coma. Neck scars could indicate past vascular or thyroid surgery.
The eye exam sounds particularly rich with information.
It really is. Conjunctival swelling could mean heart failure. Yellow sclera suggests liver disease. Specific corneal rings for Wilson's disease. Looking inside the eye, the fundus can show signs of high blood pressure, diabetes, papilledema from increased intracranial pressure, or even specific hemorrhages seen with rapid pressure increases.
What about ears, mouth, skin?
Ears looking for blood behind the eardrum, or CSF leakage. Signs of skull fracture or infection source. Mouth, breath, odor can be distinctive. Alcohol, acetone and DKA. Musty smell and liver failure. Garlic and arsenic poisoning. Tongue bite suggests seizures. Skin looking for rashes, injection marks. Specific lesions like bullae and barbiturate overdose. Signs of AIDS. There's actually a table in the review linking skin findings to potential causes, examining lymph nodes, listening to the heart, checking the abdomen for organomegaly or masses, even checking stool for blood. It all adds pieces to the puzzle.
It's amazing how much you can gather just by looking and touching when the patient can't tell you anything. Okay, we've covered a lot. Definitions, mimics, the initial approach, the general physical exam. Maybe this is a good point to pause. Next time, we could really dive into the specifics of the neurological exam itself.
Sounds good. The neuro exam is where we get into the nitty-gritty of localizing the problem and assessing severity level of consciousness in detail. Those breathing patterns, pupils, eye movements, motor responses.
Right, and we still need to cover differentiating toxic metabolic from structural coma, brain herniation, those prolonged states like PVS and MCS, and the whole topic of brain death.
Exactly. There's still a lot of important ground in the Bradley Review to cover on stupor and coma.
Okay, so the neurological exam. This seems like the core part for figuring out what's happening in the brain. The review mentions three main purposes.
That's right. First, it helps determine the cause of the coma. Second, it establishes a baseline to track changes over time. And third, It provides crucial information for determining the patient's prognosis, their likely outcome.
And what are the most helpful parts of this exam for prognosis and figuring out where the problem might be?
The review highlights 5 key components: the state of consciousness itself, the respiratory pattern, the pupil's eye movements, both spontaneous and reflexes like doll's eyes and calorics, and the motor response to stimuli.
Let's start with consciousness. How do you assess that precisely? It's not just awake or not awake.
No, definitely not. Precise description is key. You need to document exactly what stimulus was used: auditory, visual, painful, in a specific response. Start with verbal commands, then escalate to painful stimuli if needed, being careful not to cause injury. You note the maximum level of arousal achieved, what it took to get there, and exactly what the response looked like. Purposeful movements suggest milder impairment. Even just vocalizing to pain can indicate a lighter level of coma.
Is that where scales like the Glasgow Coma Scale come in?
Yes, the GCS is widely used, especially for initial assessment in traumatic brain injury. It scores 3 things: eye-opening, motor response, and verbal response. Adds up to a total score. But it has limitations, like if the patient is intubated or has severe facial injuries.
Are there alternatives?
The review mentions the FUR score, a full outline of unresponsiveness. Was it eye response, motor response, brainstem reflexes, and respirations? Some find it gives a bit more detail, especially regarding brainstem function.
Okay, next, respiration patterns. You mentioned earlier these can point to specific brain areas.
Yes, they can be quite localizing, although you always have to consider metabolic causes too. Normal breathing is quiet, regular. Noisy breathing usually means airway obstruction. The brainstem has centers that control breathing based on metabolic needs, while higher brain centers influence it based on behavior.
So what are some of those patterns?
Well, there's Cheyne-Stokes breathing cycles of deep breathing, alternating with periods of no breathing, apnea, often seen with damage to both sides of the upper brain or deep structures, or even severe heart failure. Then there's central neurogenic hyperventilation, really rapid, deep breathing, often linked to pontine lesions in the pons. Apneustic breathing is like a prolonged gasp, pause, then short expiration points to mid to lower pons problems.
Yeah.
Cluster breathing is irregular groups of breaths, again, lower pons. And ataxic respiration is completely irregular in rate and rhythm that suggests damage down in the medulla, which is very serious. There's a figure in the review showing these patterns. Kismol, breathing deep, regular, rapid, is typically metabolic acidosis, like in DKA.
Wow, quite specific. What about pupils? Size and reaction to light.
Hugely important. Pupil control involves both sympathetic nerves, which dilate the pupil, originating way up near the thalamus, and parasympathetic nerves traveling with the third cranial nerve from the midbrain, which constrict the pupil. Light triggers a constriction reflex. So abnormalities can pinpoint damage from the thalamus down to the pons, warn of herniation, and help differentiate structural from metabolic causes.
What kind of abnormalities?
Thalamic damage often causes small but reactive pupils. Midbrain damage can cause various things, often mid-sized and fixed, non-reactive pupils. Pontine damage typically causes pinpoint pupils, very small, but often still reactive if you look closely with magnification. Asymmetry between the pupils is always significant. A dilated non-reactive pupil is a classic, urgent sign of pressure on the third nerve, often from uncal herniation. You have to rule out eye drops or previous eye injury.
Okay. And eye movements. This sounds complex in an unresponsive patient.
It is, but it tells you a lot about the brainstem's integrity, from the pons up to the midbrain. If eye movements are normal, even the reflexes, it suggests that whole pathway is largely intact. We look at the resting position of the eyes. Are they deviated? Are they conjugate, moving together? Then spontaneous movements, if any. And finally, reflex movements.
What kind of resting deviations are meaningful?
Eyes conjugately deviated to one side might suggest a lesion in the frontal lobe on that side, or maybe a seizure starting there. If the eyes look away from a paralyzed side, it's usually a hemispheric problem. If they look towards the paralyzed side, it suggests a brainstem problem, often in the pons. Downward deviation can be seen with brainstem issues or metabolic problems like hepatic coma. Skew deviation, where one eye is higher than the other, often points to a posterior fossa lesion.
And spontaneous movements.
If they're purposeful, like tracking, that rules out coma, think locked-in syndrome, or maybe pseudocoma. Slow, conjugate roving eye movements back and forth usually mean the brainstem pathways are okay. And the problem is either metabolic or involves both cerebral hemispheres above the brainstem. Other spontaneous movements like ocular bobbing, rapid down, slow up, often point to severe pontine damage.
What about the reflex movements, doll's eyes?
Right, the oculocephalic reflex, or doll's eyes.
Yeah.
If you turn the head side to side, the eye should normally move conjugately in the opposite direction like a doll's eyes stay fixed forward. If this reflex is present, it means the brainstem pathways connecting the vestibular system to the eye movement nerves are working. But you absolutely do not do this if there's any question of neck injury. Absence or abnormal responses tell you there's likely brainstem dysfunction.
And caloric testing.
Caloric testing, or oculovestibular reflex, is more potent. You elevate the head slightly and gently irrigate one ear canal with cold water. In a comatose patient with an intact brainstem, this should cause slow tonic deviation of both eyes towards the cold water stimulus. In an awake person, or someone feigning coma, you get nystagmus fast beats away from the cold side. Absence of any response to cold water implies severe brainstem dysfunction or possibly certain drug effects.
Okay, finally, the motor system. What are you looking for there?
We look at resting posture. Is one side flaccid? Any spontaneous movements like seizures or myoclonic jerks? Then we apply painful stimuli centrally like a sternal rub, or peripherally like nail bed pressure, and observe the response. Is it purposeful withdrawal, or is it abnormal posturing?
Posturing, like decerebrate and decorticate.
Exactly. Decorticate posturing is flexion of the arms. Extension of the legs suggests damage above the brainstem in the hemispheres or thalamus. Decerebrate posturing is extension of both arms and legs, suggests damage in the upper brainstem, midbrain, or pons. Decerebrate is generally considered a worse sign than decorticate. These postures can occur spontaneously or only with stimulation, and they can indicate worsening pressure or herniation.
What about reflexes?
Basic reflexes like muscle stretch reflexes might still be present even in deep coma. The plantar reflex, Babinski sign, is usually extensor, toes go up, in coma from almost any cause, but should become flexor, toes go down, on recovery if there's no underlying structural damage. Muscle tone asymmetry, one side tighter or looser than the other, usually points to a focal structural lesion. Acute brain damage often causes initial flaccidity, while metabolic coma usually causes symmetrical decrease in tone. Generalized flaccidity is seen in brain death.
This leads into the concept of brain herniation, which sounds critical.
It is. Herniation is when increased pressure forces brain tissue out of its normal compartment. The two main patterns are uncal and central. Uncal herniation involves the temporal lobe pushing down, compressing the third nerve early on, causing that dilated pupil, and then the midbrain. Central herniation is more of a downward push from the top, causing progressive dysfunction from the diencephalon down through the brainstem, often with small but reactive pupils early on, then respiratory changes, then posturing.
And it progresses downwards.
Typically, yes, in a rostrocaudal deterioration. Though sometimes things can happen suddenly, like a bleed rupturing into the ventricles causing rapid pressure changes. The key is early suspicion. Signs like decreasing arousal, subtle breathing changes, even before dramatic posturing or pupil changes, can be early warnings. Increased blood pressure and slow heart rate, that Cushing reflex, are often later signs.
Okay, so a huge part of the initial workup is differentiating between those big categories. Toxic metabolic coma versus structural coma. How do you tell them apart?
History is a big clue. Was there an underlying illness, medication use? Was the onset abrupt, suggesting structural, like a stroke or bleed, or more gradual, suggesting metabolic or toxic, though there are exceptions. Response to emergency therapy helps too. Did they wake up with glucose or naloxone?
And the neurological exam findings.
Structural lesions often cause focal or asymmetrical signs, weakness on one side, pupil asymmetry, gaze preference. Toxic metabolic disturbances usually cause symmetrical findings. Consciousness level often waxes and wanes more in metabolic coma, whereas it might be steadily declining in an acute structural problem.
What about pupils and eye movements?
Pupil reactivity is often preserved in metabolic coma, even if other brainstem reflexes are gone. That's a key differentiator. Exceptions include severe hypothermia or overdose with certain drugs like barbiturates or atropine. Fixed unreactive pupils, especially asymmetric ones, strongly suggest structural problems. Similarly, roving eye movements are more typical of metabolic coma, while asymmetric eye movements or palsies point to structural issues.
Any other clues? Adventitious movements. Muscle tone.
Restlessness, tremors, myoclonic jerking, non-rhythmic muscle twitches are more common in metabolic or anoxic states. Muscle tone tends to be symmetrically normal or decreased in metabolic coma, whereas structural lesions often cause asymmetry in tone.
But it's not always straightforward. Can they mimic each other?
Absolutely. Some structural things, like subarachnoid hemorrhage or meningitis, can present diffusely, mimicking metabolic causes. And some metabolic problems, like severe hypoglycemia or liver failure, can sometimes cause focal signs. Plus, someone with an old stroke might develop a metabolic coma, and their exam will show both the old focal signs and the new diffuse ones.
What about differentiating psychiatric causes, like pseudocoma, from true coma?
Again, history might give clues, but the exam often reveals inconsistencies, things that just don't fit a known neurological pattern. Eyelid examination is helpful in true coma. If you lift the eyelid, they usually close slowly and gradually. Someone feigning coma often actively resists opening or clamps their eyes shut tightly. They can't really mimic that slow, passive closure.
Any other tricks?
Pupils usually constrict normally to light in true coma if the pathways are intact. Roving eye movements, if present, are hard to fake and suggest true coma. And caloric testing is very useful. The tonic deviation towards cold water without the fast corrective phase nystagmus is characteristic of coma. An awake person, even pretending, will usually have nystagmus or react strongly, often waking up due to the vertigo induced.
Okay, let's talk about lab tests and other studies. What's most helpful?
There's a whole list in the review. Arterial blood gases are essential, checking oxygen, CO2 levels, acid-base status, basic metabolic panel checks, electrolytes, glucose, kidney function, liver function tests, thyroid studies, sometimes cortisol levels for adrenal issues. Toxicology screens are often mandatory if the cause is unclear. Checking blood osmolality can estimate alcohol levels or suggest other toxic ingestions. CK levels check for muscle breakdown. Coagulation studies are needed before an LP.
What about non-blood tests, ECG, imaging?
ECG is standard looking for heart attack, arrhythmias that could cause low brain perfusion, or signs related to electrolyte problems. Neuroimaging is critical. A non-contrast CT scan of the head is usually the first choice. It's fast and good for showing bleeds, masses, hydrocephalus, signs of herniation.
Better than MRI initially.
Often, yes, for speed in detecting acute blood. MRI gives much better detail, especially in the brainstem, and for detecting early strokes or inflammation, but it takes longer and patients need to be stable. CT might miss very early strokes or inflammation or certain types of subdural hematomas.
What about EEG, electroencephalogram?
EEG is very useful in specific situations. It can confirm non-convulsive seizures, which can cause coma. It shows characteristic patterns in certain metabolic encephalopathies like liver failure, triphasic waves, or herpes encephalitis, periodic discharges. It also helps confirm states like pseudocoma, locked-in syndrome, PVS, and ultimately brain death, where it would show electrocerebral silence or a flat line.
Evoked potentials, ICP monitoring.
Evoked potentials test pathway integrity, like sensory pathways through the brainstem. They have some prognostic value, especially after cardiac arrest. Absent cortical responses are a very poor sign. Intracranial pressure monitoring is used mainly in severe traumatic brain injury management to guide treatment aimed at reducing brain swelling.
This brings us to prognosis. Predicting outcomes sounds incredibly difficult.
It is, hugely. Unless someone meets brain death criteria, you can never be 100% certain. We rely on general statistics based on cause, exam findings over time, and now increasingly some imaging and electrophysiologic markers.
How does prognosis differ by cause?
Generally, drug-induced comas have the best prognosis for recovery if treated promptly without secondary injury, like lack of oxygen. For non-traumatic coma overall, the outlook is often guarded, maybe only 15% making a good recovery. Yes, traumatic coma prognosis is generally better than non-traumatic coma of similar initial severity, especially in younger patients. Prolonged coma, even months, doesn't necessarily rule out a good outcome in trauma, although significant disability is common among survivors. Predictors include the initial GCS score, pupil reactivity, eye movements, motor response, and importantly, age-older patients do worse. Specific MRI findings of damage in deep white matter tracts are also unfavorable.
And the persistent vegetative state, what's the outlook there?
PBS can usually be reliably diagnosed after about 12 months for traumatic brain injury, or 3 months for other causes like anoxia. Recovery of awareness after that point is exceedingly rare, essentially unreported after 3 years. Those rare miracle awakenings you hear about usually involve patients who are actually in a minimally conscious state, not true PVS. Mortality in PVS is also high.
This leads us to the formal criteria for brain death. The review covers this in detail.
Yes. Brain death means irreversible cessation of all functions of the entire brain, including the brainstem. It's legally and medically equivalent to death. Before you even start the assessment, you have to meet prerequisites.
Like what?
You need an established irreversible cause for the coma. You have to rule out confounders, severe hypothermia, core temp needs to be above 36 degrees C or 97 degrees F/No, drug intoxication, need to allow time for drug clearance, maybe check levels, severe metabolic disturbances, No residual sedatives or paralytics. You might need to check nerve stimulation if paralytics were used. Blood pressure needs to be adequate, and sufficient time needs to have passed since the initial injury.
And the clinical exam itself, what must be absent?
Complete unresponsiveness to any stimuli. Absence of all brainstem reflexes. Pupils fixed and dilated. No corneal reflex, blinking when cornea touched. No eye movements with doll's eyes or cold calorics. No facial grimacing to pain. No gag reflex. No cough reflex when suctioning the airway. Spinal reflexes might still be present, but no purposeful motor response or posturing.
And the apnea test.
That confirms the absence of respiratory drive from the brainstem. You pre-oxygenate the patient, ensure normal CO2 levels, then disconnect the ventilator while providing passive oxygen. You watch closely for any respiratory effort for 8–10 minutes. An arterial blood gas is drawn at the end. If there are no breaths, despite the CO2 rising to 60 mmHg Hg or at least 20 mmHg Hg above baseline, the test is positive, confirming apnea.
Are other tests like EEG or blood flow studies required?
In the U.S., brain death is primarily a clinical diagnosis based on the exam and apnea test. Ancillary tests like EEG showing silence or studies showing no blood flow to the brain, angiography, transcranial Doppler, nuclear scan, are usually only used if parts of the clinical exam can't be reliably performed or sometimes based on hospital policy. They're confirmatory, not usually mandatory.
Once brain death is determined,
The time of death is documented usually when the apnea test criteria are met or when the confirmatory ancillary test is completed. Then the difficult conversations with the family occur. It shouldn't be a surprise. They should have been updated about the grave prognosis. Explaining that the patient has died but their body is being supported artificially is crucial before discussing organ donation. Organ procurement organizations are legally required to be notified and typically approach the family separately about donation. If the family objects to donation or ventilator withdrawal, support continues while legal or ethical conflicts are resolved. Eventually, cardiovascular collapse usually occurs even with support.
Okay, let's shift slightly to Chapter 6, which focuses more on those prolonged disorders of consciousness. It revisits the definition of consciousness.
Right. It emphasizes that consciousness involves both wakefulness or arousal, mediated largely by the brainstem activating system, ARAS and thalamus, and awareness, which involves widespread cortical networks, particularly association areas. It also mentions key neurotransmitters involved, like norepinephrine, dopamine, serotonin, acetylcholine.
And it reiterates the main ways coma happens.
Yes, either direct damage to those arousal structures in the upper brainstem or thalamus, or diffuse damage to the connections between them in the cortex, or compression from swelling or masses. Importantly, damage limited to just one cerebral hemisphere doesn't usually cause lasting coma.
So building on PVS, the vegetative state, Chapter 6 calls it unresponsive wakefulness syndrome sometimes.
Yes, that term is sometimes used to emphasize the presence of wakefulness, eye-opening sleep-wake cycles, but the complete absence of signs of awareness. The key clinical feature remains: no evidence of sustained, reproducible, purposeful responses to the environment. They might startle, have primitive reflexes, make random movements or sounds, but there's no interaction, no command following, no visual tracking.
And the underlying damage.
Typically widespread damage to the cerebral cortex or the white matter connections beneath it, or severe thalamic injury, but with relative sparing of the brainstem, which allows wakefulness and autonomic functions to return.
The chapter revisits the prognosis for VS-PVS.
It reiterates those timeframes recovery, unlikely after 12 months post-trauma, 3 months post-anoxia, though exceptions are noted, especially in younger TBI patients. It really stresses caution in prognostication and avoiding rigid cutoffs, as some late improvement, usually to a state of severe disability, is possible. It also highlights the challenge of assessment and the potential for misdiagnosis, sometimes estimated quite high, although those figures might be inflated. Use of standardized scales like the Coma Recovery Scale Revised, CRSR, helps improve accuracy.
And contrasting again with the minimally conscious state, MCS.
Right. MCS is defined by those reproducible but minimal signs of awareness we discussed, following commands, yes/no responses, intelligible words, purposeful behavior like reaching or adjusting to stimuli. The boundary between severe MCS and emergence is defined by achieving reliable functional communication or object use.
MCS is more common than VS?
Yes, studies suggest it is. And it can be subclassified into MCS plus, showing some language processing, and MCS minus, only non-language behaviors like visual tracking or response to environment. There's also emerging research using fMRI to identify covert consciousness or cognitive motor dissociation. where patients show brain activation to commands even if they can't physically respond, blurring the lines further.
Does MCS have a better prognosis than VS?
Generally, yes. The potential for further recovery is significantly higher than in VS. Predictors for improvement include the duration of MCS, shorter is better, the cause, traumatic brain injury generally has better potential than anoxia, and age. Recovery can sometimes continue slowly for years, especially after TBI.
What about using imaging like fMRI or PE scans in these prolonged states?
It's an area of intense research. Structural MRI can show the extent of injury, and certain patterns correlate with outcome. Functional MRI, fMRI, looking for task-based activation, like imagining playing tennis, has shown responses in a small subset of clinically VS patients. The significance is debated. Does it truly mean awareness? Maybe, maybe not. It could be automatic processing. Practical limitations are huge, too.
And PET scans, looking at brain metabolism.
FDG-PE shows glucose use. VS patients typically have globally reduced metabolism, especially in front of parietal networks. MCS patients often show intermediate levels, less severe dysfunction. PE might be better at predicting lack of recovery than presence of it, but again, false positives and negatives occur. It's mostly a research tool currently. Machine learning analyzing early fMRI patterns shows some promise for prediction, but it's not widely available or definitive.
Are there any effective treatments for chronic disorders of consciousness?
Sadly, there are no established, proven treatments. The focus is largely on supportive care, preventing complications, and intensive rehabilitation. One trial showed the drug amantadine, given for 4 weeks, accelerated the pace of recovery in patients with chronic VS or MCS due to traumatic brain injury, but the overall outcomes were still often poor.
Other things being tried.
Lots of things have been proposed. Other drugs like stimulants or dopamine agents, electrical brain stimulation, like deep brain stimulation, BBS, targeting the thalamus, sensory stimulation programs, music therapy. But the evidence for most is weak, based on small studies, often with mixed results, or high risk of bias. Thalamic DBS is under investigation, with some anecdotal reports of improvement, but it's hard to separate effects from spontaneous recovery or rehab.
The chapter ends by revisiting brain death and then touching on ethical considerations.
Right, reinforcing the clinical criteria for brain death as the determination of death itself, and then moving into the incredibly difficult ethical landscape surrounding prolonged disorders of consciousness.
How do families grapple with this, especially with research suggesting potential hidden consciousness?
It's immensely distressing. That research, while fascinating, can add ambiguity and complicate decisions if not interpreted carefully, considering the limitations and potential for false positives, negatives. Surveys show the public finds withdrawing life support more acceptable for VS than MCS, reflecting the perceived importance of consciousness and interaction. Financial cost, while a societal issue, seems less of a driver for individual family attitudes.
But many cases are more straightforward clinically.
Yes, often the prognosis is clearly very poor based on the clinical picture and imaging. Decisions then ideally rely on the patient's previously expressed wishes, perhaps through an advance directive, or the surrogate's best judgment of what the patient would have wanted, substitute judgment. Importance of advanced care planning really comes through here. Still, caution is needed, especially in younger patients, without devastating imaging findings.
And ethical tensions can arise even with brain death.
Sometimes families object to brain death testing or declaration, often due to misunderstanding or religious cultural beliefs. Medically, the determination is based on the neurological exam findings. It doesn't require consent. However, if families object strongly to withdrawing support after declaration, institutions typically provide support while seeking legal or ethical resolution, though cardiac arrest often intervenes.
It's a lot to take in, complex medically and profoundly difficult emotionally and ethically.
It truly is. Understanding these states requires grappling with the neurology, the limitations of our current tools, and the deep questions about life, consciousness, and personhood.
So wrapping up our deep dive for today, we've journeyed through the spectrum of altered consciousness, from stupor to coma, looked at conditions that mimic it, the critical first steps in assessment and care, and the complexities of prolonged unresponsiveness and brain death, all guided by the Bradley Neurology Review.
We tried to provide that structured understanding, breaking down these really complex neurological concepts.
It's definitely heavy material, touching on prognosis, end-of-life decisions, difficult topics. Hopefully this discussion has provided some clarity.
Maybe a final thought to leave you with is just, Considering that delicate balance between measurable brain function, our subjective experience of awareness, and how our evolving understanding continues to shape medical practice and those really tough ethical choices.
Something to definitely keep thinking about. Thank you so much for joining us for this deep dive.